Okay. Good morning, good afternoon, and good evening to you all. You are all welcome to this webinar from Commitment to Coverage, Accelerating Government Action on UHC in commemoration of this year's UHC Day celebration. My name is Edunri Aderemi, and I'm the Regional Advocacy Manager for Anglophone Africa with Pathfinder International. And I will be your moderator for this webinar. To kick off this webinar, I would like to invite Pathfinder International Africa President, Lydia Saloku, to please give us a very welcome address. Over to you, Lydia.
Thank you, Edrin. Thank you, Edrin. Good morning, good afternoon, and I'm really happy to be here. I'm Lydia Saloku. I'm the president of Africa for Pathfinder, covering 13 countries in Africa, and I'm really happy here to give an opening remark. Distinguished government representative of Uganda and Pakistan, WHO AU representative through Dr. Ambrose Talisuna, Senior Health Advisor Program at WHO Liaison Office, to African Union and United Nations Economic Commission for Africa, dear CSO member through Dr. Yai Sophia Job at UHC Civil Society Engagement Mechanism, dear colleague, dear champion on health equity. A few Sundays ago at my local church in Ouagadougou, I sat with Mariam, who just spent 6 months saving on her youngest child illness. A few days later, at the pharmacies, another mother approached me to help her add some money so that she can afford basic medication for her ill child. These aren't isolated stories. There are scenes that unfold every day across Burkina, my country, but also across other countries in the continent. And when WHO tell us that 4.5 billion people lack access to essential health medication and services, I see Mariam's face. When we discuss the 2 billion individuals facing devastating financial hardship due to healthcare costs, I think of every parent I have watched negotiating the price of medicine, wondering which milk they will skip to afford treatment. The WHO last UHC monitoring report presents us with a stark truth. Global progress on health services coverage has stagnated since 2015. That number, however shocking, means also our collective failure. Every statistic represents a family forced to choose between medical care and their next meal. In Africa and in Asia, where 97% of health-related poverty occur, this choice is not theoretical. It is a devastating reality. At the same time, as you know, we are gathering today through multiple crises our health system is really struggling under the wave of climate emergencies, conflict, and persistent inequity. And the theme, health is on government, arrive at a moment when only 2 African nations have met the Abuja Declaration, the 50% healthcare budget target. It's 23 years after this commitment, we are still struggling to reach this target. And most of our nation is putting barely half of this amount. And this is not just a failure of financing, it's a failure also of imagination and political will. Yet, I stand before you with determined optimism. I'm still optimist because we need to be optimists. Across our focus country, we see some countries who are really doing well, like in Kenya. Community health financing initiatives are reaching those long left behind. In Egypt, the National Unified Health Insurance Plan is reimagining coverage for millions of Egyptians. In Pakistan and Uganda, they are putting innovative partnership and result-based approach are showing a new pathway to universal coverage. This means it is possible. It is possible when we have a political will, when we want really to put action, when we take a commitment. And at Pathfinder, we understand that UHC is not merely a technical challenge. It is a fundamental human right. Our mission to advance the well-being of women and girls intersects perfectly with the imperative of UHC. We see how access to sexual and reproductive health services, climate resilience health system, and women economic empowerment all contribute to the broader goal of health for all. And I'm particularly eager to hear from our distinguished panelists today about how we can radically reimagine our support to country. How do we move beyond the progress we are seeing to go for a transformative change? How can we forge partnership, a real and truly partnership to shift power dynamics and resources where it's needed to help achieving our goal of UHC? This demands concrete answer and concrete commitment and action. And the path of universal coverage, health coverage, requires more than technical solution or model or modest reform. It demands a fundamental transformation in how we value human life and dignity. And today I look forward to hear from the panelists and also from you bold ideas and commitment that will emerge from our dialogue. Together, we must build health system that truly leave no one behind, not at a distance aspiration, but as an urgent imperative. And let us begin this vital conversation, this time with aspiration of change, with the aspiration of action. And we hope today we will really sharing what we are able to do in country, but also what will be the next step we want to take to move our stagnation to action. On this note, I would like to call back Adrian to take over this session. And I hope this dialogue and this webinar will bring us with new engagement, not engagement in terms of declaration, but engagement in terms of action. Let's act for our population. Thank you so much. I forgot to say merci.
On your behalf, I'm saying merci. Merci, Madam Lydia, for your warm welcome speech. We are expecting our keynote speaker. If he's online, he can join us, but if not, I can still go ahead. Dr. Ambrose Otai Talisona, our keynote speaker from WHO AU Liaison Office. When you come online, do let me know. So thank you once again, Lydia, for your welcome speech. And once again, thank you all for joining this webinar as we commemorate the 2024 UHC Day. It is really important to reaffirm that the goal of universal health coverage is to ensure that everyone is able to obtain the health services they need without suffering financial hardship. This webinar provides us with a critical platform to reflect on the UHC progress made to ensure financial protection, sharing lessons from Pakistan, from Uganda, and from Egypt, and also discuss actionable strategies that translates commitments into concrete actions and results. Today, we are joined by an exceptional panel of experts, including representatives from the Civil Society Engagement Mechanism, from government leaders from Uganda and Pakistan, and also from Pathfinder Egypt, who will share their insights and experience in driving UHC agenda in ensuring access to healthcare with adequate protection from financial hardship. Together, we will explore how collaborative efforts can accelerate access to quality, affordable healthcare for all. So let's dive into this vital conversation. I would like to call on my first speaker, Mr. Chris Mugarura. Mr. Chris is the Assistant Commissioner, Health Services, Planning, Financing, and Policy, Ministry of Health, Uganda. Over to you, Mr. Chris.
Thank you very much for the opening remarks. And I have already been introduced. I'm Chris Mugarura from the Ministry of Health, Uganda, and I will be making my presentation on behalf of the government of Uganda and the Pathfinder country office. Let's move. Next. We are looking at successful community health initiatives and results-based financing in Uganda. A summary of some major statistics. The population of Uganda. Uganda is not a very big country. The population now stands at 45.9 millions. This is as per the census of 2024, which has just been concluded. And we have a GDP of US dollars 45.56 billion United States dollars. And the population in poverty, as per the State of the Uganda Population Report 2022, stands at 20.3%. And life expectancy at birth now has increased to 68.2 years. And total fertility rate is at 5.2 births per woman. The UHC service coverage index is at 6.5%. This is an increase from 46% in 2017, 49% in 2021. Out-of-pocket expenditure for total health is at 29%, representing a reduction from 41% in 2018-19, 29% in 2020-2021 financial year. And the proportion of population accessing health insurance is still low. In 2018-2019, we're at 3.9, and it has reduced to 2.1 in 2022-23 financial year. What is the health financing landscape in Uganda? As per the annual health sector performance report, which covered the financial year 23-24, as you can see, the total health expenditure for 2020-2021, development partners contributed 45.4%, households 29%, and the government of Uganda 25.6%. And the trends in terms of health budget allocation as a percent of the total national budget has almost stagnated between 7.2 in 2019-2020. The following year, it reduced to 6.1. Then, as of now, 2023-24, it has increased to 7.7%. The per capita expenditure, it has increased between 2019-2020 from 16.6 US dollars to 22.4 in the financial year 23-24. Next. Other key results as per the annual health sector performance report, maternal mortality ratio is now at 44%, and this is a reduction from 336 to 186 per 100,000 live birth. Neonatal mortality is at 18%, which is a reduction from 27 to 22 per 1,000 live birth. Under 5 mortality, it has reduced to 18.5%, and infant mortality now stands at, has registered a reduction of 16.5%. In terms of VHTs, we have managed to train 28,302. And community health workers, we have so far trained 334 community health extension workers who are deployed to provide services at household level. What is Uganda's experience? We have developed a community health strategy, which has been developed and disseminated. We have scaled up evidence-based high-impact interventions, e.g. immunization and ICCM. Introduction of village health teams since 2001. Community health extension workers have been operationalized. So far, 973 community health extension workers completed a 6-month training in 7 pilot districts. And we have scaled up to 10 districts to train 1,294 community health extension workers. Electronic community information management system has also been piloted and is being scaled up. And we have since institutionalized this financial year, in fact, institutionalized results-based financing for primary healthcare, which has been integrated in the government of Uganda, PHC financing. Then the National Health Insurance Scheme was established in the year 2002, but to date it has not kicked off. But the bill has been submitted to the cabinet. It's pending approval to be forwarded to Parliament for approval. We have increased access and utilization of PHC services, which are provided at the lower level public health facilities. Then the available GOU PHC grant for private not-for-profit facilities, this one only covered 37% of the private not-for-profit sector, leaving a huge gap of 63%. We also have inadequate GOU per capita allocation to the health at US dollars 22.4 against the recommendation of WHO of US dollars 86. And health insurance coverage is only at 1% in Uganda, which is still very low. Thank you, ladies and gentlemen, for listening to me.
Thank you. Thank you so much, Mr. Chris. It is exciting to see the giant strides the government of Uganda is taking towards ensuring that UHC commitments are actually translated into tangible outcomes. I'm aware now that we have our keynote speaker online, Dr. Ambrose Otai, who is the WHO AU Liaison Officer. If you're online, can you come up and please give us your keynote speech? Thank you. Then we can continue afterwards.
Can I share my slide, my screen?
No, you don't need to, sir. Thank you. You
Okay,
can
thank
just
you.
come up camera.
It's telling me I can't start the video. I don't know why. Hello?
Yes, I can hear you, sir. You can just go ahead. I will rectify that at the back end. Over to you,
All
sir.
right. Thank you very much for the opportunity, and I would like to thank Pathfinder for allowing us to share some insights on this universal health coverage day, which is tomorrow. My name is Dr. Ambrose Dalisuna, and I'm Senior Health Advisor Programs at WHO Liaison Office. And as a background, and I've just heard from the presentation in Uganda, is that really, while there is political commitment for UHC and a clear roadmap for the WHO African region, the UHC monitoring report shows uneven progress and even stagnation in several countries. For the period 2000 to 2019, there was some progress, with the Health Service Coverage Index, and with the Health Service Coverage Index, which are ranging from about 28% to some 75% across member states. However, the proportion of the population facing catastrophic spending, which is over 10% or more of household income out of pocket health costs, increased from 7.7% to 8.4%. In 28 member states, up to 29% of health expenditure still comes from out of pocket. And this is really one of the challenges. But as Africa, we also have to, we are seeing that we accounted for 69% of the global maternal deaths. So maternal deaths remains a big challenge in Africa. And I think we need to increase access to maternal intervention. But the region also has a disproportionate burden of child deaths, accounting for 33 of 54 countries globally. We have to contend with communicable diseases, but also at the moment we have to contend with non-communicable diseases, which increased from 24% in 2000 to 37% in 2019. In addition to that, Africa has to contend with public health emergencies, ranging from infectious disease epidemics to disasters and humanitarian crisis and conflict. Indeed, conflict and violent settings are creating difficulties in providing health care. And so we have to deal with FCV context, probably by developing health in the humanitarian development and peace nexus. The other issue that we have to contend with is actually the negative impacts of climate change. Now, moving forward, I think with UHC, we need to review our partnerships and how we deal to deliver universal health coverage. And here is why. For us to deliver universal health coverage, first of all, we need to have pandemic preparedness and response. And that will require for us to be able to have partnerships where we can share information in real time, as well as work with logistics companies so that we can be able to deliver our interventions. The other issue that why we need increased partnerships is climate change. Climate change is a big threat in the 21st century. It's escalating threat. We are seeing new vector-borne diseases. We are seeing malaria in areas where we didn't see it. We are seeing extreme weather conditions. And this will require us to work across partnerships with industries focused on sustainability and urban resilience, renewable energy, so that we can mitigate the impacts and build climate resilient health systems. The other challenge that we are seeing that requires us to look at broad partnerships is the epidemic of antimicrobial resistance and the epidemic of non-communicable diseases. Really, the epidemic of AMR is driven by overuse of antibiotics in humans and animals and agriculture. Again, we need to work across sectors for food production, pharmaceutical companies, to be able to deliver UHC. So we need to broaden our partnerships. UHC and delivery of health services to address health inequities will require us to look at innovative financing models. You've had the presentation from Chris in Uganda, but we need greater inclusion of marginalized populations. So we need new partnerships with microfinance institutions, insurers, grassroots organizations for better financial management. So as WHO, what are we saying in terms of what should we do to ensure that all people living in the world are enjoying good health and well-being as a fundamental human right? We need to establish resilient health systems able to promote, provide, and protect health and well-being for all people across the world. And this is really in our WHO General Program of Work 2025-2028. And she has 6 strategic objectives. The first one is, for us to promote health, we need to respond to climate change, which is an escalating health threat in the 21st century. But we also need to address the health determinants and the root causes of health of ill health in key sector policies. We need to be addressing the sectors and making sure that health policies, that we have policies that are favorable for health in the other sectors. For us to provide health, we need to advance the primary healthcare approach and essential healthcare capacities for universal health coverage. We need to improve health service coverage and financial protection to address inequity and gender inequalities. And finally, for us to protect health, we need to prevent, mitigate, and prepare risks from all hazards, emergency hazards. We need to rapidly detect, sustain, and effectively respond to all health emergencies. So to sum up, really, health systems in Africa have often been chronically underfunded, fragmented, and under-resourced. We urgently need resilient health systems with fit-for-purpose essential public health functions and adequate resources at all levels. Health systems that can effectively leverage robust global health security capacities and fundamental universal health coverage interventions such as primary healthcare, essential health facilities, health workforce, and affordable medicines and supplies are in a better position to protect their citizens against the social and economic impacts of any shock event. I thank you for your attention.
Thank you, thank you. Thank you so much, Dr. Ambrose, for still taking time to give us your keynote speech. Thank you so much. We will now continue with the speakers, and our next speaker is Basma Ganem. Basma is the Financial Inclusion Team Lead with the Women's Economic and Social Empowerment Program, a program funded by USAID and implemented in Egypt by Pathfinder International. Pathfinder Egypt is partnering with the government of Egypt, community members, and the private sector to implement the Women Economic and Social Empowerment Program. And part of the intervention is the Financial Inclusion Initiatives that includes women's access to micro-insurance. Basma will be sharing with us the status of Egypt's ongoing National Unified Health Insurance Plan, highlighting Pathfinder's intervention that promotes women's access to health coverage. Over to you, Basma.
Thank you, Edrin. Hello, everyone. Greetings from Cairo, Egypt. Very happy to be on this panel. If we can please put up my slides, Edrin.
Sure.
Yes, thank you. So through this panel, I'm going to provide a quick overview of what Egypt is presenting or has on the agenda in terms of UHC. And I'll also speak a little bit about how our program is supporting women's access to insurance, but more at the private sector level until the national UHC reform program kicks fully in. So if we go to the next slide, a very quick overview of the Women's Economic and Social Empowerment Program. It's a Pathfinder implemented program in Egypt. It's funded by USAID. It's a 5-year program. And there are 3 main objectives that we're working towards. The first is improving the work environment for women in the private sector economy. The second, which I'm responsible for, is expanding women's financial inclusion. And the third is reducing the socioeconomic impact of violence against women. All 3 objectives are intertwined to forward the socioeconomic benefit of underserved and low-income women in Egypt. If we go to the next slide, before diving into Egypt's UHC framework, let's take a quick look at Egypt's foremost reform program, the Egypt 2030 vision, and specifically the health pillar under the reform program or under vision, which targets providing Egyptians with high-quality healthcare system that ensures protection specifically for vulnerable populations. And this ties closely in with the UN SDGs and specifically SDG number 3, which forwards good health and well-being. To achieve the Vision 2030 pillar in Egypt, the following KPIs were set by the Egyptian government in 2015. The first was to raise per capita health expenditure from $152 to $600, so almost more than 3-fold. The second was to decrease out-of-pocket health spending from 60% to 28%. And the third KPI was to increase the ratio of citizens fully covered by health insurance from 58% back in 2015 up to 100%. If we go on to the next slide, we'll have an overarching look at the current UHC system in Egypt, or it's the UHI, Universal Health Insurance System. Historically, Egypt has been challenged by low public investment in health with large out-of-pocket expenditures. However, in 2014, the government took a decision to double government spending that goes towards the improvement of health systems from 1.5% up to 3%. This offered an amazing opportunity to improve our national health systems and to work towards achieving a robust UHC system. A universal health insurance system was designed by the government in 2015 to cater to the entire Egyptian population with quality health services that they need to support them so that they live their lives without suffering hardship from a health perspective. Target population include the most vulnerable, such as the elderly, disabled people, the poorest Egyptians, and those working in the informal sector. So if we look quickly at the timeline of how our national UHC has been developed, in December 2017, the Egyptian government passed a bill to ensure universal health insurance for all Egyptians. Implementation of the bill was planned to take place over 6 phases over a period of 10 years, so that would extend up to 2027. The following year in May, the law entered into force and its implementation decrees were released. In October of 2018, 3 new agencies were established by the Egyptian government to support the national UHI system. The first is the General Healthcare Authority. It was established to coordinate the provision of healthcare, and to become responsible for all the health facilities that are owned by the Ministry of Health and Population. The second authority is the General Authority for Healthcare Accreditation and Regulation, and this one was established to devise and oversee an accreditation criteria for outpatient care, hospitals, and pharmacies to make sure that the quality of the services offered is the best possible quality. The third organization that was established as part of this infrastructure was the Universal Health Insurance Authority, and its role is to collect contributions and handle the risk management processes and purchase health services. In early 2019, a line item was added to the national budget to cater to and specifically cover the Universal Health Insurance System. And the funding for this was raised through tax collection and is stored in a dedicated account with the Central Bank of Egypt. In July 2019, the UHI scheme was actually launched in one of Egypt's governorates on the Suez Canal. It's called, or a governorate is a city. It's called the city of Port Said. And this city was selected in specific because of its small size, limited population, and it had somewhat an existing capacity in the health system in comparison to other governorates in Egypt. So this was designed to be a quick win and a model that could be replicated in other cities. So what's happening right now? What is the picture on the ground at this stage? The UHI system is currently operating in 6 out of 27 Egyptian cities, and there are over 300 healthcare facilities, and around 22 million healthcare services have been provided, and a little over 5 million individuals or Egyptian citizens have joined the UHI system. What's happening also in terms of developments that the government is trying as much as they can to digitalize the process, so to make it more efficient and have medical historical records, hopefully for the entire population. On the next slide, we're going to look at an important factor, the financing of the UHI system, which we touched upon in the previous slide very briefly. The UHI system is designed to rely on public sources of funds, like citizen-paid premiums that comes from the state budget, also government subsidization for the poor, and that's targeted to be about 30 to 35% of the population. And it's also funded from general tax, tobacco earmark tax, and fees paid by the medical facilities to subscribe to the new health insurance system as well. The premiums, all Egyptians will be covered on a mandatory basis on a stage-by-stage approach like we mentioned, and employers will contribute from the citizens themselves, the employees themselves from their salary. There will also be a deducted payment. A family provider will pay for his dependents, for his children, and for his wife. And A specific portion will also be dedicated so that the government 100% subsidizes for people who are totally unable to pay. Moving on, of course, it's a new system and fairly recently entering into the market. So if we look at the next slide, because it's a new system and it's because it's still in the initial phases of implementation, there are challenges that are faced to offer the UHI scheme to each and every Egyptian citizen. And among those challenges is, it's always that way, awareness is always an issue, lack of public awareness about the law or the UHI scheme in general and the benefits covered. But the government is trying to address this through awareness, through integrated campaigns, like face-to-face campaigns and door-to-door channels in order to make the general public aware of what is offered and how they can benefit. Another challenge is the insufficient number of eligible providers. Like we mentioned in previous slides, the government set this up so that there is an accreditation process and a monitoring process so that the health facilities that are offered to Egyptian citizens are as efficient and effective as possible. So the eligible providers are not enough to offer services under this health insurance and to cover the targeted population. A mechanism needs to be in place to do regular and frequent assessments of existing facilities to help onboard them onto the system. High costs will be incurred to upgrade healthcare facilities that are not eligible and to make them eligible for accreditation. As a result, a lot of service providers are shying away from the process, and because of the hefty capital investments that it will require. And also access to beneficiaries or eligible citizens is an issue. A lot of uncategorized beneficiaries who are able to pay premiums are hard to reach. And NGOs and the CDAs that operate under them can play an important role in finding those eligible citizens and starting to generate success stories. Moving on, I'd like to tell you about an activity that we're doing under the Women's Economic and Social Empowerment Program. Until the UHI system in Egypt has been fully rolled out, the private sector plays a crucial role. They have to come in, support, and stand in to offer insurance or health insurance to the general population. But there are two core challenges associated with the private sector playing that role. The first is, again, at this layer, at this micro layer, a lack of awareness of microinsurance and a lack of the means to access microinsurance products and exercise them efficiently. And in case of awareness, confidence levels in insurance coverage are not so high among this population. So our program's intervention directly address those challenges through offering financial literacy to target female beneficiaries and facilitating linkages between our female beneficiaries and financial service providers. In our case, it will be microinsurance that covers health and other aspects as well. The program is currently in partnership with an insurance provider that offers a wide range of highly affordable microinsurance products, including hospital cash and medical coverage. This insurer operates through a community-based agency mechanisms where individuals or champions are recruited and deployed at the community level to promote awareness and onboard beneficiaries onto the company's microinsurance products. This partnership came as a perfect fit for the program because we already work with ministries and NGOs through a TOT and cascading modality when it comes to financial inclusion. We're working towards recruiting our financial literacy trainers that are housed within our partner Government of Egypt entities and NGOs, where we're working to integrate those as agents of our partner insurance companies. Those facilitators are known and trusted members within their communities, and therefore they are in a position to boost women's confidence in insurance and support their onboarding onto it. Thank you very much, and on to you, Adrian.
Thank you so much, Basma, for that very insightful presentation. Our next speaker, I'll move on to Mr. Javed Ali Jagirani, who is the Chief Executive Officer, People's Primary Healthcare Initiative, Sindh in Pakistan. It is worthy to know that the UHC system in Pakistan has evolved over the years. Mr. Javed will share with us Pakistan's UHC system, how it has evolved over the years, and examining how People's Primary Healthcare Initiative approach is expanding coverage while ensuring financial sustainability for primary and secondary health facilities. Over to you, Mr. Javed.
So, Madam Admin, this is Riyad Raojo, Chief Operating Officer. So, could you please give chance to another panelist because CEO Saab is joining within 15 minutes.
Okay, that's fantastic. Thank you for letting us know. I would like to move over to Yaye Sofietu Diop, who is a member of the Civil Society Engagement Mechanism Advisory Group and also the Advocacy Manager for Speak Up Africa. The civil society engagement mechanism is a key part of the UAT 2030 movement that advocates for universal health coverage policies that are equitable and inclusive, ensuring that the voices of civil society are heard in the UAT 2030 policies and guidelines. Yaya is a representative of the civil society. As a representative of the civil society, can you share more insights on CSEM's role and efforts towards ensuring countries meet up their UHC commitments from policy to actual implementation and impact with practical recommendations on how you think countries can accelerate progress? Over to you, Sophie.
Thanks a lot, Edrin. Good morning, all. Good afternoon, good evening, depending on where you are. And also thanks a lot, for inviting me and for inviting, the CSEM constituency to participate to this important webinar, And as you already mentioned, my name is Yaye Sofietu Diop. I am the actual director of partnership and development at Speak Up Africa, and I am based in Dakar, Senegal. Bonjour to all of my Francophone folks. And I'm also a AG member of the Civil Society Mechanism for UHC 2030, Coming back to CSEM, it's a civil society constituency, of UHC 2030, a global multi-stakeholder movement, for universal health coverage, And what we are mainly doing, is to convince civil society voice, to ensure that UHC policy are inclusive and equitable, And CSEM, and also with our network of more than 1,015 organizations around the world, we exist because, we believe that civil society organization, has a vital role to play in achieving, universal health coverage, and mainly to ensure that no one is left behind. And one thing, I really want to highlight, and I really think there is really a need to come back to that, is really that universal health coverage, is a critical global goal, aiming to ensure that all people have access to quality health services without financial hardship, And however, if you look at the UHC, if you look at, what's happened in the global south in general, I think we all know one person, or we all, was in one situation where it was really difficult to have access to health care, services or infrastructure. And there is really a need to highlight the fact that, access to UHC is not really, something with simple, but beyond that, it's a matter of equity, and there is a need to put on a special emphasis on that. Also, over the past 2 decades, there is really a need to highlight that governments had made, commitments to deliver health to all, and achieve UHC. And if I look at in the African region, I know we often talk about the Abuja Declaration. And the last, report that the African Union shared, we realized that more than 25 countries, did really work on that. And I think this results, it's just because we have civil society organizations who are mainly pushing in order, to have a concrete impact and just to be part of the discussion, so that they can highlight or they can share, the voice of all of the person, mainly the communities. And coming back, to the role of civil society organization in general, civil society organizations are shaping the health policy. They mainly advocate for policy change, that are taking into account, equity, accessibility, and accountability in health system. And they are mainly the voice of all of the marginalized communities, and ensuring that the needs of vulnerable population are addressed when we are discussing, around UHC policy framework. And for CSEM, it's mainly a platform, for civil society organization. And our role is to see how we can amplify the collective voice of civil society organization. And for example, the CSEM group, has been mainly instrumental in ensuring that civil society voice are heard at the United Nations and World Health Assembly last year, but also this year. And the mechanism advocates, for equitable health financing and inclusion of civil society in the monitoring implementation efforts. And beyond that, in terms of example of successful partnership, I can mainly take two examples. The first one in Africa is mainly linked, to Tanzania. For example, in Tanzania, civil society organization, really partner with the Tanzanian government in order to raise awareness and advocate for increased, funding for maternal health services, And all of these joint efforts, really help to have more resources, allocated to maternal health, resulting in improving to access to service in rural areas. And I also can take the example in Benin, where civil society organization in collaboration with the parliamentarian, did advocate in order to increase the resources allocated to the fight against malaria. And in 2022, the budget for malaria was doubled. And this year also, we also have an increase with more than 25%. And all of this result is just because, civil society organization was behind. If I come back to Philippines, in Philippines, mainly, civil society organization really work on the UHC Act. This group really play a key role in developing, the Universal Health Coverage Act in Philippines by organizing, a couple of consultations with local communities and engaging with policymakers, And all of the objectives we, the civil society organization had at that time is mainly to ensure that the act was inclusive, and address, the need of marginalized population. We really have many examples, but the main idea is really to highlight the fact that, civil society organization has a big role to play. We really want to take our place, and we are building, in order to ensure that we are part of the discussion and we have a concrete impact. In terms of practical recommendation, I think there is really a need to strengthen collaboration with governments. And governments really need, to actively engage civil society organizations in decision-making processes and policy development, And I think it's why it's important for the civil society organization to be part, of all of the national networks we have at the country at the country level. And I can take, the example of the Global Fund mechanism, for example, for the fight against malaria, if I can take this example, And there is really a need, I think, for this specific component that countries, institutionalize, mechanism that brings CSOs into the policy-making process, but because it not need to be just a one-shot. There is really a need, that the system is strengthened and the CSO voice, is just an obligation. There is also, in terms of recommendation, the second one, is to support, capacity strengthening activities for CSOs, mainly in low-income countries, We have many civil society organizations that are doing, a great job on the ground, but in order to access, to the decision-making process, there is really a need, to have a technical support and capacity building in order to actively engage them on UHC in general, And for that, we think that governments, other international partners, like Pathfinder, like the work that CSEM is actually doing, we really need to prioritize, funding and technical support for civil society organization. Also, in terms of recommendation, there is a need to ensure that a meaningful inclusion of marginalized population. And I think it's beyond people living, with physical disabilities, for example. There is a need to include all of the people living with intellectual disabilities, who most of the time are left behind, so that we ensure that women, people living with disabilities, population, refugees, really can participate to the discussion so that they can bring their own perspective, And also there is a need to advocate, for accountability mechanism. As civil society organization, our role is not only doing advocacy, but also playing this accountability mechanism role. And for that, CSO must be involved in monitoring the progress of UHC from budgeting and service delivery to achieve, of health outcomes, I just close my speech by just highlighting the fact that, the path to achieving, universal coverage requires all of us, government, civil society organization, international partners to work together by strengthening our partnership, investing in communities, but also ensuring that accountability, we can accelerate, progress and move closer to achieving UHC for all. Thanks a lot, Adrienne.
Thank you. Thank you so much, Sophia, too. Truly, the critical role of CSOs cannot be overemphasized in achieving UHC and also in advocating to countries on delivering their UHC mandate. Thank you. Our next speaker, if he's here, is Mr. Javed Ali, the Chief Executive Officer, People's Primary Healthcare Initiative, Singh, Pakistan. Mr. Javed is online. Are you online? Do we move over to questions and answers? If you see,
Thank you.
Okay.
Fine, I'll just need a few seconds. Will you please share my presentation?
Thank you. Mr. Javed, just give us a few seconds while the presentation comes up. Thank you.
Yes, I'm here. Can you please share my presentation so that I may start, Ms. Adrienne?
I hope you can see your slide now.
Thank you.
Over to you.
Thank you very much. My apologies for late joining since I was committed somewhere else, and it's really pleasure to joining this webinar. I'll right away start with my presentation. So I'll be basically touching upon what PP CSEM is doing, what PP CSEM, my organization is, and how we are contributing towards ensuring UHC in its true spirit. Next, please. Okay, this will be sequence of my presentation. I request you move ahead. Next slide. So this slide basically shows, by this slide, I want to just connect what PP CSEM is doing and what are in terms of key focus areas as far as UHC is concerned. So when we talk about financial risk protection under UHC and to provide quality and affordable essential medicines and access to quality essential health services to people, this is what PP CSEM has its core objective. Since PP CSEM basically healthcare services provision at Sindh province of Pakistan, and when we know that primary healthcare basically the cornerstone of UHC. So by doing that, we are contributing towards strengthening PAC services at province of Sindh of Pakistan, and ultimately towards gaining achievement by implementing UHC through 14 and 39 health facilities what we manage. And by this way, we are achieving this global goal of sustainable development goals. So in that process, we are basically providing maternal and child health services, nutrition services, free of cost immunization services, and also we ensure availability of essential medicines and vaccines at our health facilities. Next, please. So when we talk about theme of today's webinar, that is health, basically it's on part of government. So that I'll touch upon, I'll correlate with our mission, that is PPHISN, which basically our organization works with government of Sin since this provision of PHC service happens to be core. So government of Sindh has basically entrusted this duty, this responsibility to PPH Sindh through one MOU, and the arrangement happens to be public-private partnership. We basically are a private company, a not-for-profit company working on behalf of government and provide quality primary healthcare services. Next, please. Profile of PPH Sindh. By this, we can assess how PPHISN is contributing towards provision of PHC services in far-flung and hard-to-reach areas of Sindh province. We do have access in 26 districts out of 30 districts of province of Sindh, and we have catchment population of 20.1 million. In this province, we do manage 1439 health facilities, whereby in 320 health facilities, we do provide 24/7 BMONC facilities. Then we have CMONC facilities also, which are 13 number. So I'll just request the panel to focus on the first two numbers in the table that basically shows number of OPD services what PPHISN are providing. We provided these services, PHC services, to around 37 million people in financial year 22-23, and which increased basically to 42 million in 23-24. And again, we are seeing this increase for this current year. So by this profile, we can assess, you can make an estimate how entrenched and how far this services of PPHI are in terms of provision of PHC into to maximize services towards path of ensuring UHC. Next. Next, please. So when we talk about PPHISN contribution towards cut out-of-pocket cost, which happens to be core objective of UHC, I just put forward figures of performance of 2 years, that is 2023-24 and 22-23. Like when we say that is the financial year, previous financial year, we provided OPD plus ANC plus NVD and C-section services to around 46 million patients, and with an average per patient cost of 285 PKR Pakistani rupees, and total 13 billion, which equals to 49 million US dollars. So this is basically this is the cost of services which we are providing free of cost to all our clients, which is spread out in all of the 26 districts of Sindh province, including all hard to reach areas. So here by this, we basically are addressing this particular core objective of UHC, that we are providing these services and we are cutting out of pocket costs. Next. So one slide back, please. Yes, when we say how a PPHI is doing in terms of equity and impact upon society while providing the services, so just I have brought forward 3 main components, that we are in a continuous process of transforming patient care, whereby we do provide, as I already mentioned, 42 million people services in continuously improving manner, and that is the reason people are more and more coming towards PPHI health facilities, and government is also showing trust. We have a diverse workforce focusing upon gender equity, and we have this particular mission to drive equity and impact further as far as our services are concerned. Next, please. When we talk about collaborative efforts to achieve UHC targets, PPHI likewise do believe in collaborative approach. I'll just quote few examples in this regard, which under which PPHI Sindh is basically working in a systematic manner to achieve UHC. We have launched a pilot project in one of our districts of Sindh province out of those 26 districts, that is Chandu Alayar, with support of Government of Sindh, AKU, and BMGF, international partner, where we have a target to achieve 100% UAC coverage in that particular district, and there will be pilot which will ultimately be replicated in other districts also. This table basically shows where we currently stand, whereby as far as those indicators are concerned, interventions are concerned, somewhere we are 31%, we are fully achieved, and we have also achieved partially, and few are there which we can't achieve. Obviously, we've approached Government of Sindh to help us in order to achieve 100% of these interventions. Next, please. So moving ahead, I'll just further define how collaborative approach is driving PPHI Sindh towards achieving UHC. We have the one very key partnership with Pathfinder also, that is building healthy families, which was implemented by both the partners. Then again, we had a specific project during flood emergency at Sindh, and generous support of 32,000 of RUTF was also provided by Pathfinder for same children and for our nutrition services. Next, please. So this is next two slides basically show the list of all those engagements and partnerships what we are having with Government of Sindh, and for different other programs for maternal nutrition, for child nutrition, and we are having in partnership with World Bank also. So next, please. And that basically substantiated how collaborative approach is basically implemented by PPHI Sindh. Thank you very much. I hope I have been able to convey and to showcase how PPHI Sindh is basically contributing, what PPHI Sindh is, and how it is contributing to achieve core objectives of UHC in Sindh province. Thank you.
Thank you so much, Mr. Javed. Thank you. It is great to see the PPHI initiative is really helping out of pocket reduction in accessing healthcare for the people of Sindh in Pakistan. Thank you. I will now be taking questions from the chat box. I think we have one question. Let me read it out quickly. So this question is from Gladys Asu, who is a journalist at the Cameroon Radio Television. And a question goes, considering Cameroon's financial constraints and the critical need for public buy-in since the country began rolling out its UHC plan in 2023, what specific strategies can the government adopt to sustainably finance UHC while ensuring equitable access and fostering trust and participation among the populace? Thank you for that question, Gladys. I would like to pose that question to Sophie, if it's okay with you, Sophia, too. Can you attempt to answer? Thank you.
Yeah, thanks a lot, Edrin, and thanks a lot, Gladys, for raising this important question. And I think this question, really highlight the duality we have, in terms of financing the, universal health coverage, while ensuring, equitable access and building trust, In terms of some of the strategy, Cameroon can adopt, I will just share, some of the ideas that just come onto my mind. The first one, is perhaps to just diversify, the financing mechanism. because as we already know, in all of our African countries, we really have budget constraint. And in terms of approach, perhaps there is a need to increase all of the PPP approach, around private sector partnership, in terms of identifying, innovating financing mechanism with them. We also can explore, expand the tax base. I know in our countries it really take place, to ensure that in terms of taxes, we take into account, we increase, the amount of tax. But I think, perhaps having, expand the tax on tobacco, alcohol and others, can really help in terms of developing financial mechanism. But one thing is really important, and I think beyond Cameroon, African countries really need to put an emphasis on that, is really to strengthen the governance and transparency. And in order to do that, there is really a need, to have the civil society organization, participate to the discussion so that, in terms of accountability mechanism, they really can, share with the communities in general what the government is doing actually in terms of we can access to UHC coverage. And in order to do that, when we develop all of the budget at the country level, just strengthen, all of the consultation we are having, for example, what's happened in Benin, where they have, a community consultant, a community consultancy mechanism that's really help, to bring the community voice and ensuring, we build trust and we also, tackle the need in UHC. But in terms of approach, it's mainly, ensuring that we build transparency, we develop, financial mechanism who are really innovating and taking into account the need of the poor, but also see the possibility to put more resources, on digital health, because I think, the power now we have, is mainly linked to digital health, and all the things linked to telemedicine and others, really help, to access to universal health coverage in general.
Thank you, Sophia, for trying to answer the question. Thank you very much. Dr. Ambrose Talisina, I think you put something down. Would you like to come off camera to also add? Is there something you'd like to add to the question?
I think Sophie really addressed most of the things. Yes, but if you look at most of the countries, I think they really need to the tax GDP ratio is very low, so you could still do a little bit more with resource mobilization and from taxes and then budget support for the health sector. But the other is really some countries where we have seen insurance schemes working as part of the financial strategy, and social solidarity for predicted illnesses. So in addition to what Sophia said, I think for me, I think we still can do a lot more with increasing the tax to GDP ratio, and then to add more domestic financing of the sector, of the health sector for UHC, but also really scaling up social insurance schemes. Over.
I totally agree with you. Thank you very much, Dr. Ambrose. I hope your question has been answered, Gladys. Thank you. Thank you all to our amazing speakers, for sharing insights from the different regions represented here. As we come very close to the end of the webinar, I would like to call on Dr. Mohamed Abuna, the President Pathfinder International, to please summarize discussions and just, give us a closing remark. Over to you, Dr. Mohamed.
Thank you very much, Adrian, and good afternoon, everyone. My name is Mohamed Abunar. I'm the interim president for South Asia, Middle East, and North Africa, and it's a great honor to be here today. So, dear government representatives of Uganda and Pakistan, dear WHO, AU representative through Dr. Ambrose Talisina, Senior Health Advisor Program at the WHO Liaison Office, to the African Union and the United Nations Economic Commission for Africa, dear CSO members, also through Yaye, Sophie, to Diop of the UHC Civil Society engagement mechanism. Dear colleagues, ladies and gentlemen, it is with great appreciation that I take the floor this afternoon to make the closing remarks of this extremely important virtual platform intended to make the commemoration of this 2024 Universal Health Coverage Day celebration. The theme, from commitment to coverage, accelerating government action on UHC, challenges all of us, governments, organizations, and individuals, to move beyond promises and take concrete steps toward inclusive, equitable, and resilient health systems. We've heard today about innovative strategies, shared inspiring success stories, and explored pathways to overcome the barriers that stand in the way of achieving UHC. So I want to extend my deepest appreciation to our distinguished speakers and representatives from the WHO, African Union, the civil society engagement mechanism, and the governments, and our dear colleague from Uganda. Your insightful presentations have not only highlighted the strides we've made, but also the pressing challenges we must address to make universal health coverage a reality for everyone, everywhere. At Pathfinder International, we remain steadfast in our commitment to supporting governments, empowering communities, and working collaboratively with partners across countries to make UHC a reality. Together, we can ensure that health systems are not just robust, but also equitable, serving the needs of women, youth, and the most marginalized population. Today's discussions have reinforced the urgency and necessity of transitioning from commitment to tangible coverage, ensuring that every individual, regardless of where they live, can access the quality health services they need without financial barriers. We're therefore asking our governments to continue to introduce laws, budgets, policies, and programs that reduce financial barriers and protect people from financial hardship when accessing essential health services, prioritizing those in the most marginalized and in vulnerable situations. As we conclude today's session, let us leave with renewed energy and determination to champion UHC in our respective spaces. Let us hold ourselves and our governments accountable to accelerate action and sustain the momentum toward health for all. Pathfinder celebrates this event every other year, and each time we hope you join us again. Thank you once again for your participation, and I look forward to seeing the incredible progress we can achieve together. Let us keep the conversation alive and the action rolling. Stay inspired, stay committed, and let's make UHC a reality for everyone. Thank you very much. Back to you, Edwin.
Thank you, Dr. Mami. Thank you, everyone. Enjoy the rest of your day. Bye-bye.
Thank you all.
Thank you, Edwin. Thank
Bye.
you.
Thank you.
Thank you
Bye.
all.
Bye.
Thank you.
Bye.
Thank you all.
Thank you.
Thank you. Thank you.